Hi, everyone. My name is Kayla Reddick, and thank you all for attending today. I was diagnosed with breast cancer at 24. I went through the full gauntlet of chemo, a double mastectomy, radiation, and finally to hormone therapy, which I'm 5 years into. I'm cancer-free today, and my side gig and passion project is through a film called Vincible, detailing the young adult cancer experience, which is the demographic I do advocacy work for. Today, I am thrilled to share the screen with my doctor and truly one of my personal heroes, Dr. Ann Partridge from the Dana-Farber Cancer Institute. Dr. Partridge is the Vice Chair of Medical Oncology at Dana-Farber Cancer Institute. She founded the program for young women with breast cancer, the Young Women with Breast Cancer program, and is the director of the Adult Survivorship Program. She's a medical oncologist focusing on the care of women with breast cancer, and she has a particular interest in the psychosocial, behavioral, and communication issues in the breast cancer care and treatment. Now, I imagine many of you joined us for this webinar today to deal with questions on how COVID-19 is affecting you, whether or not you're considered immunocompromised. And so please submit questions through the chat function. We kindly request that all questions are in the general format and not specific to your own care or situation. So hi, Dr. Partridge, and thanks for being here today.
Well, I will say it is a pleasure to see you, Kayla, and to be with all of you today in these extraordinary circumstances, which of course are not a pleasure. And I think the big picture is that we're all going to get through it, but it's a really hard time for everybody. And I think gatherings like this, sponsored by YSC, are really great to pull us all together and to think about what we can do to protect ourselves and our loved ones and our patients and our friends and and the public in general.
Absolutely. And we really appreciate your time, just because obviously the internet has a lot of information, but it's always good to go to the experts. So that's why we called you here today. And just to kind of frame this conversation, I think a lot of young adults get skipped over in health conversations. I'm seeing a lot of the COVID-19 talk geared towards 65 and up. And so let's just think about the more younger population when we're talking through this. And so, Dr. Partridge, let's just start. What does it mean to be immunocompromised? And more importantly, who is considered immunocompromised?
Sure. And I want to step back a little bit from that and say that low risk doesn't mean no risk. And so while the risk categories that we've heard about from the CDC, which all of us are familiar with, the higher risk groups, over 65, chronic heart disease, lung disease, kidney disease, severe asthma, HIV, or living in a nursing home or other kind of long-term facility. Those are the ones that the CDC puts out there. And then there's immunocompromised NOS, or not otherwise specified, which is, I will answer that question. But I think one thing we all need to keep in mind is that just because you're not in one of those high risk groups doesn't mean you're not at risk. And, it's not common, but people of all ages can get very sick with the coronavirus, although it's a lower likelihood the younger you are in particular, or the healthier you are. So I think in that general context, the immunocompromised folks comprise a group of people that are either have innate, meaning inside their body from either birth or change over time, being lower likelihood of being able to fend off something that would attack, like a bacteria or a virus that comes from within, or it can come from without due to medicines like chemotherapy or another virus like HIV that came and infected them. And so that's general immunocompromised. But other things can make people relatively immunocompromised, like a recent flu could make you more likely to be immunocompromised for another infection. A recent surgery, or not eating well or sleeping well, like malnutrition or severe fatigue if you're overworked, can make you immunocompromised relatively. So there's like big I immunocompromised, and then there's little I immunocompromised. So even in my own family, where we're blessed with being healthy, I'm making sure that my family actually eats well during this time, sleeps better than ever during this time because, of course, yours truly and many like me are used to not sleeping that much. And I'm saying, you know, the last thing I want to do is be like a little under and a little more predisposed when I'm going out and seeing patients who might be infected, right? And so that's kind of little I immunocompromised. So there's a wide spectrum of immunocompromised.
Gotcha. What about long-term survivors and how this would affect us?
Yeah, so I think there's a couple different buckets when I think about people who might be listening. You know, Young Survival Coalition, right? We've got young survivors, including women, mostly, maybe some men too, living with active disease who are getting treated right now for cancer. And then there are people who, and that includes women who are being treated to get rid of it forever, or for whom they're living with it and it's becoming a chronic condition. And then there are women who have been treated in the past and are now, you know, without evidence of disease, and maybe it could be 10, 20 years ago, right? So there's a different degree of recent exposure that we need to think about. So if you start with people who are undergoing active treatment right now, it really depends on what the treatment is and other underlying good health. So let's just say a healthy person who's, you know, just had surgery or just had radiation, okay, no other thing on board. That person is little I, maybe a little bit immunocompromised just because, you know, coming out from a surgery, coming out from radiation, you may be a little more predisposed to things because you're tired, you're feeling the side effects of these things, but not dramatically so. But for those people, I'm saying, you know, take it easy and really socially distance. For a person who's getting chemotherapy, that person is pretty immunocompromised. Even with breast cancer, where our chemo tends to be more mild than chemo that we give for things like leukemia, where they get rid of your bone marrow almost. We give, you know, a more moderate chemo, but it can still make you immunocompromised. And so people in that setting, I'm saying, you know, I really want you isolating. I want, you know, almost pretend like everybody else around you has COVID, and, you know, you can see your loved ones, but if they get the sniffles, keep them far, far away, because I don't want that person contracting COVID, let alone getting even any other infection that might land them in the hospital and put them at risk during this difficult time. So that's the chemo. And then there are people who are either on hormones or on nothing, who are far out from treatment, right? And if you have metastatic disease or early stage disease and you're just on hormones, in theory, you're not really immunocompromised, especially if you're far out from surgery, radiation, or chemo. It's unpleasant. I don't want you, any of my patients getting, or any of you out there listening, getting COVID, but those folks should not really be particularly immunocompromised in a big I way. They may be having hot flashes and staying up more than they would, and not sleeping well, or stressed out and not sleeping well. And that could lead them to that kind of little I immunocompromised. So we got to work on those kinds of things and managing the symptoms so that they aren't truly immunocompromised in a big way. Does that make sense?
Absolutely. So long-term survivors, we really got to think about our lifestyle choices more than ever during this time to support
Right. But I think the disease itself in the back, you know, in the rearview mirror, as long as you're at least 6 to 12 months out, and that varies from person to person, from things like chemo in particular, or, you know, radiation in of itself, or surgery in the past, is not going to make you, as long as you're far out, shouldn't make you immunocompromised, with rare exceptions for that and for chemo in the remote past. The one thing that we've brought up with our infectious disease folks is that they do think that people who got radiation, especially if they had a significant amount of their lung involved, which is fortunately not something we do in breast cancer anymore. We're very good at blocking the lungs. But if you had to get really deep radiation for some reason, then you may be a little more at risk of a complication from a pulmonary standpoint if you got COVID. We're not sure it makes someone more likely to get COVID, and they're probably not immunocompromised anymore if it's way in the back, you know, mirror. But the bottom line is you may be a little more at risk of complications if you've had exposure to radiation and had some lung damage in the past, kind of like someone with a history of asthma or something like that.
Okay. Now, are there any quantitative markers aside from white blood cell count to determine if you're immunocompromised?
So So there are, but not things we would routinely be testing. So there are plenty of tests. If someone has a known immunocompromised kind of state, like they've been on chronic steroids, or they've had a history of chronic infections and therefore have been worked up for that kind of thing, then there are antibody workups we do. There are certain kinds of blood tests that we do, but generally we're not screening for those things in folks. And it really is more about what's your history, and err on the side. If you're not sure, err on the side of assuming you might be somewhat immunocompromised. But your average breast cancer survivor would not be expected to be profoundly immunocompromised in a big I way, and especially if they're not on any more therapy anymore, and especially if they're over 6 months or so out from chemotherapy.
Okay, and so that does kind of tangent to the next question of about how long from your last chemo treatment does it take for your immune system to get back up? Maybe going from a big I to a little I.
Yeah. Or hopefully you're sleeping okay. And, I mean, that's another big component we can talk about, was like, how do we all manage the anxiety? And I think for many of our survivors living with disease or in the past, this is both, I think this could be very traumatic, right? Another huge blow, an event that we're all struggling with. And if you're still fragile, as many people are from their recent or not so recent breast cancer experience, it can just, I think, for some of my patients, seems to be pushing them over the edge. From a resilience standpoint, some of my patients are telling me, you know what, this is child's play for me. I've been living with risk and I can handle it. So it's very interesting, the different things I'm hearing from patients. And obviously you support people where they are. But to address your question, which I lost my train of thought. What was your question again?
About how long after your last chemo treatment does it take for the immune system to be back?
So this has been looked at in studies not related to COVID. And we think that most people are recovered from the acute toxicities of chemotherapy within most people clinically, it's about 3 months. Then 6 months is where we say, yeah, you should expect the white count to be all back to normal. Some people earlier, obviously. Some people can still have a lot of fatigue, still going out to a year. And then there are some people who go on for longer with the fatigue or the little I parts. There are also the very rare things that can happen to people where they do have real big I problems that result from their chemo. Fortunately, this is something like people can get leukemia in the couple of years after chemotherapy. It's a known risk. It happens to about 1 in 1,000 people with breast cancer therapy, with the kind of garden variety breast cancer treatments. Not all of them put people at risk, but some of the chemotherapies. And so that's extraordinarily rare. So I guess the other piece of the message is, if you are feeling bad physically, profoundly, and no matter what I say, you could be immunocompromised if you're feeling ill. So this would be a time, it would be a horrific coincidence that somebody got a secondary leukemia in the middle of all this.
Right.
But it happens, and in the general public, people are still getting diagnosed with other kinds of cancers and with leukemias and things like that. So certainly reach out if you're not feeling well. And I always tell my patients, a lot of times people go back to their primary care. And if you're 10 years out and everything's in the, really far out, go to your primary care. But if you're still in the first couple of years after a diagnosis of breast cancer, especially if you're living with disease, you're being treated chronically, I want people to reach out to me, because I'm going to have, not me personally, for everybody out there, but you should reach out to your oncologist, I think, because we're going to have a little bit better of a thinking around how immunocompromised you might be, and what your last white count is, and what chemo you got or not, and what you're at risk for. So we might have a more nuanced approach to your care, and whether you should be tested for the virus if you develop any symptoms, whether you should isolate or just do social distancing and things like that.
That makes sense. Finding out the best information you can for your specific case and health.
Yeah.
Another question from, how do we determine, do targeted therapies for metastatic breast cancer make patients big I or little I immunocompromised?
Yeah, so it really depends on the target. It really depends on the therapy. It's interesting. So, I'll go through a few of them because I'm sure people will have questions. So really interesting is we have no idea what the immunotherapies are going to do in the setting of COVID. There's a lot of research going on trying to understand that. So the hot new treatments in cancer are to do these take the brakes off the immune system treatments. That's the immunotherapies, and allow our immune systems to work against the cancer, sometimes with chemo, sometimes not. In breast cancer, it's usually with chemo. And we have no idea whether that's going to be good or bad against the COVID virus right now. So we're doing a lot of looking at what's happening to people right now in our clinics around the country to try and sort that out. You should all be happy to know that ambitious researchers have been like literally fighting to do more to learn about how people with cancer are affected, at all types of cancer and all stages of the disease in breast cancer, trying to understand better how we can help people both now and in the future about COVID, but we don't have a whole lot of answers yet. So for immunotherapy, it's really a curious thing because we're not sure if taking the brakes off will be a good thing, but it could be. Those people may be more immune. We don't know. That's one. Two, people with targeted therapies, like a lot of people may be on things like the CDK4/6 inhibitors, drugs like ribociclib, abemaciclib, or palbociclib. Those are targeted therapies. They do, some of them more so than others, can lower the blood count, and that could make someone a little more immunocompromised. And so in our practice, we're taking it person by person, but we're tending to hold off on adding them if we have concerns for that person, either their ability to distance or their counts have been low before. We may pull that off for a little while, just as we get through this surgy time in the medical system. That's a targeted therapy. The anti-HER2 therapies are also targeted therapies. That's the pertuzumab and the trastuzumab and some of the oral agents. We don't know that they would have an effect biologically. It's not likely that they would have a strong effect on the innate immune system or the immune system in general. But as long as the cancer is under control and the cell counts are okay, because they're usually given with chemotherapy. For each patient, we're kind of weighing the pros and cons of what treatment to continue or what treatment to start, depending on how they're doing, the rest of their disease, and how low their counts might have gone in the past, or whether you need to give things with steroids. So steroids make people immunocompromised and make them predisposed potentially to viral infections, and bacterial potentially too, and PCP, a type of pneumonia. So we're trying very hard to leave steroids out of as many regimens as we can, even for the people we're still treating, or minimize it in this setting. So that's another big area.
So, and when you do talk about white blood cell counts, what is considered low? Below a 4? What's, from your professional opinion? Mm-hmm.
Yeah, so that's a good question. And it really depends on kind of the person's normal, because some people live normal, but I tolerate a very low blood count for patients, depending on the pros and the cons of what I need to move forward with. But as many people know, the viral infections are actually not fought first line by the neutrophils, which is what we need for chemo to be up. Viral infections are more fought by the B cells and the T cells of our immune system. And those we don't typically measure very well. We do measure them in things like HIV, but we don't measure them routinely. So the counts are kind of a little bit of a barometer of the immune system, but they're not perfect barometer of your actual ability to fight off a viral infection. And certainly it's the antibodies made by those B cells and supported by the T cells that are doing the main fighting against a virus when your immune system reacts. So it's interesting that we use the counts as a surrogate that we use, but they're not really perfect, to be honest with you. So to get at your answer, it really depends on your lab, but 2 or 3 would be a low normal, but a low, and 4 would certainly be normal in most places.
Okay. So for another question from the viewers, for those who are going radiation right now or in the coming months, who may have to visit a hospital daily for treatment, how concerned should they be, and what precautions can they take?
Yeah, that's a great question. And again, we are all stepping back and saying, for each patient with our radiation oncologist, is the radiation necessary? And for most people it is, okay? If you're being treated with curative intent for breast cancer, we want to treat you with curative intent and not let COVID get in the way of that. And yet we're trying to minimize time spent at the hospitals. And so what we're all doing is making sure that our facilities are clean, clean, clean. I mean, literally like nutty clean. It's good. There's hardly anybody there because we're only treating the people that absolutely have to be there. In fact, when I walk into Dana-Farber right now, it's like a ghost town, and people are 6 feet apart from each other in the waiting room, and usually packed waiting rooms. I'm actually running on time. If anybody knows me, I'm never on time in clinic. But it's shocking. I can't wait to get back to my old bad habits. Just kidding, I'm trying. And I will say that it does feel extraordinarily safe, and people are being very careful. And now in the hospitals, for sure, patients and providers are all wearing masks. Staff is wearing masks, and that actually does protect. So I'm wearing a mask to protect you because I might be an asymptomatic carrier. And now the patients are doing that as well. And again, all the people serving, the cafeteria, if people are eating any lunch, there's nobody there though, so there's hardly any service. And I'm sure that's happening at places where, especially hotspots around the country as well, for anybody obviously not listening only from the Boston, New York area. The other thing people can do, and I've been reinforcing this when I was in clinic yesterday, and what we're doing is sitting in one room, and I'm not examining people I don't have to examine. We're 6 feet distancing. I'm looking at them. They're showing me what I need to see. If they need an exam, fine, I do, and I wear gloves. I wash my hands before and after, and I'm of course wearing a mask. And if they don't need an exam, I'm saying just show it to me, and I'll just document that we did this because of social distancing, and I don't care whether the bills get paid. The good news is I think most of our healthcare facilities are saying do what you need to do that's right to keep your patients safe and treat them well. So for radiation, I know they're doing as much as they can to get people in and out, not make them sit around, at least at our place. And then the thing that I'm reinforcing with my patients is, especially if they come in and their hands are free, I'm reinforcing the hand washing, but I also, in my office, in the clinic where I see patients, I hand them a set of gloves. I give them a wipe. If they don't feel like, they want to wear the gloves, I say, just use that to, hold the door handles as you walk in and out of places. And I think that's a good idea. I go to the grocery store now and I keep wipes in my pocket and I pull them out for anything I need to touch. And I wipe everything down when I get it home. And it can get a little crazy. And we joke a lot about like whether we wipe down every grape or not. And how far can you go? But I do think we want to be prudent, especially if you're going in and out of a healthcare setting where, people are trying, but even touching the elevator buttons, I use something besides my hands. And I'm definitely, the biggest thing you can do is wash your hands before you eat, or when you come in the house, before you touch your face or anything else. And the other big culprit, I'm told, so it's your own hands on your own face is the biggest culprit from touching stuff. And then we've got to be our phones and surfaces. So putting things on surfaces and then putting your hands on surfaces also. So I've been wiping down my phone every day too, especially for people who have young kids. Before your kids play with your phone, just wipe everything down.
Good advice. So for people who are post-treatment, what's the recommendation for follow-up appointments right now versus waiting? And what about people in active treatments? What treatments can wait? What can't?
Yeah. So I think the really good news is that the U.S. government, big G and little g, local G, states and federal have made telehealth kind of the thing which should have been a long time ago. It's great to see people in person, but we're pretty good on video. And for those who can't do video, phone. And the insurance companies are stepping up and saying, yeah, we'll reimburse. And so we've moved almost all the visits we possibly can. And I know many people around the country have moved as much as they can to telehealth. So if you don't need to go back in, so say someone had surgery and they're going to need to just talk to me about what their adjuvant therapy is or whether they need X or Y, I'm seeing them by Zoom now. And it's all, it's all HIPAA compliant. We are in a private line. I even let them in from the waiting room. And we're seeing people by Zoom. And I know my colleagues around the country are doing this to give the advice. If they need, a pill type thing, then I can just send it in and fax it to the pharmacy from there. If they need an infusional thing or radiation, well, then of course they need to come into the cancer center to get that or into the clinic. But we figure out how to do that. And our groups and our clinics have done a tremendous job, at least from what I can see. And it's really hard trying to space out the time. They're working really hard, as well as the as well as the getting people in and out. So things like, we have a lot of people on Herceptin or Herceptin and pertuzumab for a year. They have to come in every 3 weeks. We used to make them come and then we'd sign the orders and we'd see them and it would, you know, blah, blah, blah. Now they're mixing it before they come in, and they're mixing it and they're just giving it to them when they get there. Now, I hope we don't go back and that we can do that in the future, because we all know that people waste a lot of time waiting for that kind of thing. And so this has kind of led us to get much more efficient and much more proactive around those things. But yeah, some people do need to do that. Sometimes you do need to come into clinic. There's nothing better than, I think, seeing someone in person, especially when you have to talk about something serious like this. But we're doing it by Zoom, and in some ways it's harder, especially when you're having tough conversations. And in some ways it's nicer because you can have, like right now, you can't bring a partner in. We're not allowed to bring a visitor. So I can look at a person in their home. I can see, I am not my nipples. I am in your back window, your back wall, and whatever other pictures and art. And it's much more intimate. And then they can see, you know, my kid run by the back, because I often sit in the pantry and grab a snack and I'll introduce them sometimes. And, you know, that's what we do when we try and keep it as like one-on-one and intimate as it can be. But I found that my patients do seem to like when I can bring in, you know, they get to bring in their loved ones. I see their kids, I see their kitchen, I see the way they've decorated. That's kind of fun. Keeps it a little lighter. Even when
more personal and intimate. It's nice to have.
So bottom line is, make it as remote as you can. When you got to go in, bring a wipe, take good care. Oh, and wear a mask. So we're giving the masks out now. But I think increasingly around the country, people are wearing masks. I know the president just, you know, said people can or should. I'm increasingly convinced that that's worth doing to protect others with the if you could possibly be infected, and it may protect you a little bit.
Good to know. So what if you're due for your Lupron injection next week? Is there another way to get the injection, or what would you recommend?
Yeah, so thank you for that question. So just to be clear, at Dana-Farber, we actually made guidelines around all of these issues, and they are posted on our website. So if you look up Dana-Farber and breast oncology, you can see what the Dana-Farber doctors are doing across the group. And there's tweaks. I'm not doing it for everybody. Individualization is fine. And we posted that not just for ourselves and our satellite colleagues, but for colleagues around the country and for our patients to see what we're doing. And that's because we did a lot of heavy duty thinking in the first couple weeks of this. And we said, okay, wait, we don't want to give a lot of steroids, and we don't want to give really toxic chemo that's going to make people more immunosuppressed. And we can't take people to the OR right now because, you know, we have to free up the ORs, right? And so we're doing a lot of preoperative and hormonal therapy right now. We've moved everybody that hasn't had breakthrough of their ovarian function to every 3-month Lupron, so they can get a shot and they don't have to come back for 3 months. And then we can, you know, dial in and see how they're feeling if we need to do a visit in between. So that, to answer your question, we're moving everybody to 3 months unless a person has had breakthrough. And we looked at the data and we decided that that's worth it. And then the other thing we're doing is, if a person has had breakthrough, or if they're brand new to it, then we might put them on tamoxifen first, even if we otherwise might have put them on an aromatase inhibitor, which is slightly better. But in a short period of time, tamoxifen is going to work even if your ovarian function has breakthrough, whereas an AI might not. And so we're kind of, you know, straddling those things for temporary measures to try and make things safe and not have to come back and check your estradiol in a month, if that makes sense.
Yeah, thanks. All right, so what is the longest time between port usage or flush to avoid going to the office or hospital?
So that's a great question. We usually try and make people get their ports flushed every month, but you can probably go up to about 8 weeks.
Okay, 8 weeks.
Yeah.
What are your?
You don't want to go longer than that, but a month is the textbook answer.
Okay. Alrighty. So what are your thoughts on how doctors may change on how to prevent COVID-19 once COVID-19 antibody testing is available?
Yeah, so we all can't wait for that, because many of us want to know whether we're immune or not, and whether I already had it, so I can like go on the front lines and help more, right? And I think it's coming soon, and when it does come, I'm sure they'll prioritize by likely exposures. I mean, more importantly, I'd like to see a vaccine, and that'll be hopefully within the next year, if not sooner. And this hopefully will die down at some point, because we're all doing such a good job social distancing anyway. But it's going to be around for a while, and we just have to kind of, I think, hunker down and get through it.
Now, there is a follow-up question regarding Lupron again. for breakthroughs for Lupron injections, what does that mean?
Breakthrough means that you still have ovarian function that's going on. So that can be told by either having periods still, or clinically, or by an estradiol level. And when we first start people off, sometimes we check them, especially if they're really young, to see that their ovaries are suppressed. But we don't really want to do that right now. And so we're giving the 3-month shot, and mostly we're putting people on tamoxifen unless they need an aromatase inhibitor. And most people are going to be suppressed, so I don't want to cause a whole lot of drama here. But there is the risk of breakthrough, and you don't want to find out the hard way that the person wasn't suppressed. You want to check it. If you know, it's very different. If you're 40 and over, you're less likely to break through. If you're under 40 and young, especially if you didn't get chemotherapy, you're more likely to have your ovaries break through because they're just more robust at that age.
All right, switch gears to talk about post-chemo. So what are self-isolation restrictions for returning to work? Let's say you're 2 months out from chemo and started hormone therapy.
Yeah, so, you know, I would probably want to check your counts, make sure everything was back up. Even though we don't normally check counts, I want to see how a person felt. And I think these things are all gray about, and it kind of depends on the work you do, right?
Mm-hmm.
And how socially distanced you can be and how exposed you are at work. And I think if you're in a situation where you're going to be around people and you can't socially distance, then I'd probably want you to be a little further out if you just finished chemo 2 months ago before you had to be in a crowd in this environment.
Is it safe to pick up food?
I think it's very, I know that's hard to hear, and I think it's very independent, you know, very kind of really dependent on a lot of factors, but 2 months is pretty close to chemo and radiation and things like that. And I probably want to see someone a couple more months out at least.
What about going to farmers market, picking up food? What preventative measures can we take? Multi-wearing cloth masks? Should we be worried about passing people on the street?
Yeah, I think you want to be socially distanced from everybody. I mean, even if you're not immunocompromised, I don't want it. I don't think I'm immunocompromised, but I don't want it. I'm socially distancing from everybody, including my husband. I'm kind of kidding, but a little bit. I'm not totally kidding.
Well, you're on the front line, so.
Yeah, I mean, I don't want to give anything to him. That's for sure.
Right, of course.
I think that we're all trying to do that right now within reason. And I think, you know, if you can go to the farmer's market and you can keep your distance and you can, you know, wash your hands and that you trust where you're getting it from, or even takeout, you know, you want to, you know, you got to eat, you got to get food from somewhere. It's hard to wipe down that cheeseburger that you get or that salad.
Yeah.
So, you know, go to reputable places. Wash your hands before you eat or pick things up and bring things in. A lot of people are changing things from, you know, the box it comes in to their own plate and then washing, you know, getting rid of it and then washing their hands. Reasonable.
Okay. And I think we have just one last question here. So if someone with metastatic breast cancer usually has someone come to their home to help out, like a cleaning service, when can they start using services again? And when they come, should they be wearing a mask or gloves or any PPE?
Yeah, so I don't know the when of that. I think that when depends on the when of everybody else in the, you know, in our communities, and when things start to get lifted in the places where there has been restrictions. Believe me, I know the pain. And we all know the pain of not being able to kind of function the way we normally want to, or have somebody else clean when we're used to that, if you're lucky enough to have that. And the priority is your health and not exposing. So I would say I don't know when that's going to happen, and I don't know when, you know, a person, if you absolutely need someone to come and clean because you can't do it yourself, or you just don't want to do it yourself, which is quite reasonable. I think I would say, yeah, have them wear a mask. Make sure they don't have any symptoms when they come. Make sure they don't have any recent exposures to someone who's COVID positive, and ask them to wear gloves and a mask when they clean. And then, you know, if they can do that, then you're probably in good shape. And, you know, just keep your social distance when they come. I know that that's a big issue for not just cleaning. It's actually a much bigger issue for people regarding childcare, because, you know, the schools are closed, the daycares are closed. Some people, I have friends who are 2 doctor couples, they both need to work, and then they have multiple kids who don't have school, nanny, or daycare because they don't want to let a nanny or a babysitter in the house right now. And they're just kind of figuring it out. And I know that sounds like, you know, woe is me, play your violin, but these people are trying to do the right thing and take care of people. And yet they
Right.
don't want to expose in either direction, and they're a liability too. So they don't want to give it to the nanny who then goes home and gives it to her elderly mother. And
Right.
so there's so many levels here. And so I think just use your best judgment. I think it's probably okay for someone to, you know, you can include people in your circle as long as they're appropriately socially distancing too, as necessary. You know, there's plenty of older people who live in homes. The workers need to take care of them,
Right.
you know, and we can't say don't take care of them because you put them at risk. They got to be taken care of. And so I think if you need your house cleaned because that's, you know, you need that for sanity and hygiene and all that, then just, you know, as best you can use distance and good hygiene.
Well, thank you so much for your time. I know we're already a little bit over and I want to be mindful of your schedule. You're a busy woman on the front lines. Thank you for your work that you're doing. And thank you all for submitting questions. Appreciate you all being here. And take care, everyone, and be healthy and keep the distance. Any closing words for us, Dr. Partridge?
No, I just want to say, stay strong out there, guys. We will get through this. Definitely reach out for help if you need it, both medically, of course, call your doctors. If you're a breast cancer survivor, call your oncologist team. There's a lot out there for the anxiety around this too. And you're not weak if you feel anxious, you're normal if you feel anxious around this, just like you were normal when you felt anxious around your breast cancer diagnosis. So do reach out. There are lots of resources out there, stuff all over the web. This is where it's okay, I think, to call Dr. Google. And lots of the cancer centers and your own cancer center probably have a lot of things they're pushing out. In fact, our social workers are ready for business. They're making a ton of calls, and we all get it, how anxiety provoking this is for very legitimate reasons. So don't hesitate to reach out.
Well, thank you so much.
All right. Bye,
Have a
Kayla.
good
Thanks.
one. Bye-bye.